According to the World Health Organization, about 8 million people were diagnosed with tuberculosis last year, with over 1.2 million dying as a result of complications. In South Africa last year, 56,000 people, died of TB, and around 31,000 of those people were people living with HIV. The WHO has also noted that while South Africa is experiencing a decline in TB-related deaths, the country might not reach its targets to reduce cases by 50%. We speak now to the South African National AIDS Council CEO, Dr. Thembisile Xulu. Doc, a very good afternoon to you. Thanks very much for your time. Let's start with the positive news, perhaps the fact that there has been a decline. What are we doing right?
Thank you so much, Vuyo, and good afternoon to all your viewers. I think what we're doing right is that we have agreed that TB is a national priority across all our sectors. So be it public sector, private sector, as well as communities, we are treating the communications, the advocacy message around TB correctly. We have also embarked on targeted universal testing for TB. So no matter what you show up for at a clinic, we will screen you for TB. So we are doing things right in the sense that when we find TB, we actually start you on treatment within a week. That is Department of Health policy. And we have gone above and beyond in terms of finding our missing TB cases by using our newer technologies like the digital chest X-ray, as well as urine tests, which are more sensitive in picking up TB. I think we've also put quite a number of people on antiretroviral therapy. And when people are virally suppressed, Vuyo, and they take their treatment well, their chances of developing TB are low. So more than anything, it's making TB a priority and making sure that we screen you for TB each time you come into contact with a facility or at community level.
Sadly, we might not reach the target of reducing cases by 50%.
It's quite true. So the incidence records, we are on track, but the problem lies particularly that we are not on track with the mortality. So the mortality for TB in HIV is particularly high amongst men, and it's particularly high because we do have that high level of TB, HIV co-infection. In the stats that you have just given us, you mentioned that more than 50% of the patients that have got TB in South Africa are actually co-infected with HIV. Therefore, we find that a lot of them develop TB, and because the TB does not show symptoms, it takes them long to come and seek for health assistance. Sometimes by the time they get to see us, they've got advanced TB. We start them on treatment, and then they develop such severe complications that they sometimes actually demise. So we are finding that TB mortality remains high even in young people because young people actually, are not accessing antiretroviral treatment as much as we'd want them to. They don't test as frequently as we'd want them to. When they do test for HIV, they start treatment but fall off early. So the ones that have got very low CD4 counts actually develop TB and then would demise from TB from poor health-seeking behavior. And then I would say just generally, TB being a disease of low socioeconomic status, a disease of poverty, a disease of malnutrition. South Africa is a country of great divides. We have an extremely poor population. We have a highly mobile population. TB is very common in the mining community as well as the peri-mining communities. And we are really struggling in terms of containing mortality by keeping people on treatment, hence the move towards the simpler treatment methods and the shorter regimens.
Why do, many people take long to come forward? What are some of the contributing factors?
So some of the contributing factors is, one, we didn't recover well from getting people back on treatment post-COVID. Remember, we lost a lot of people because facilities were closed, so we didn't quite recover. But the problem, Vuyo, is that once you are immunocompromised, the CD4 counts or the soldiers in the body are so low that even when you do have TB, they can't detect the TB, therefore you don't show the symptoms. And if we do simple symptom screening, just by asking you questions and saying, do you have night sweats? Are you coughing blood? Are you losing weight? Sometimes people genuinely don't have symptoms, which then results in late health-seeking behavior. And then, as I mentioned, when we don't do the digital computerized chest X-ray on everybody, and we simply rely on TB symptom screening, we don't pick up as much TB, and we find it very late. So we are now being very deliberate in saying, especially for people with advanced HIV disease, that we do a test called the urine LAM, which has got a very high sensitivity in terms of picking up TB, in order for us to be able to treat people and to find it even in cases where it's hiding because the body is not reacting based on you being immunocompromised.
What about treatment that people or some people or sections of the populations get, like the LGBTQI plus community, get in public facilities? I'm asking this because I've had conversations in the past with your TACs who issue regular reports where they talk about discrimination but also mistreatment of people at a lot of public facilities.
It's absolutely true, Vuyo. The latest treatment action campaign reports have actually been very well received by the departments, and they still do show that there is discrimination that LGBTQI communities do experience when they come into health facilities. A lot of education has been done at health facility level, but what has been a major success is what we refer to as community-led monitoring, where you find now that community-based organizations are being contracted either by government or by donors to render services for key populations at community level. And that is where they are able to be treated by their peers. And they get access to HIV, TB, gender-affirming therapy, and these are offered by their peers, therefore with less discrimination, but with supplies and support and technical assistance coming in from the department. And it does help us to manage the minimization of stigma and discrimination and ensuring that South Africans are actually, I think, able to live in this new democracy without the hovering threat of HIV and TB.
Dr. Xulu, let me thank you for your time. We'll leave it there for today. So a lot of people, 56,000 people died of TB last year in our country, and around 31,000 of those were people living with HIV. We're experiencing a decline in TB-related deaths. However, as a country, we might not reach our target of reducing cases by 50%.